Hi everyone, students. I am Dr. Gaurav Patel and I'll be discussing this surgery questions asked in FMGE June 2022. Okay, so these are the recall based questions. Let's see the questions asked in surgery. Although most of the paper was very straightforward, all the questions were very simple. Okay, and although the questions of surgery were like more than 40, 44, 45 I guess. Okay, so surgery is a major subject in FMG, and these days, recently, but I have seen that questions what they ask are very straightforward, very simple questions. Okay, so best investigation for the diagnosis of GERD. For the gastroesophageal reflux disease, the best investigation is 24-hour pH monitoring. Okay, 24-hour pH monitoring will put a catheter, and that catheter will take the pH readings of this 24 hours. Okay, and on this, if the pH is less than 4 for more than 4% of the readings in the lower part of the esophagus, that is considered as GERD. Okay, that is considered as GERD. On this, one more thing you will see something known as DMeester score. Okay, so DMeester score more than 14.7 is also considered as GERD. Okay, so this is, although this flexible endoscopy is also done to see the changes by the GERD, manometry will show you that the lower esophageal sphincter is relaxed. Barium swallow has not much role in GERD. Okay, it is done maybe to see the associated, if there is any hiatus hernia and all, that you can see on barium swallow. Next question, which of the following confers good prognosis for the invasive ductal carcinoma breast? High mitotic index is a poor prognostic factor. Overexpression of HER2 is poor. If there is ERPR status, that is considered as good prognostic factor. Okay, ERPR positive is a good prognostic thing, but HER2 positive is a bad prognostic factor. Metastasis to lymph node is a poor prognostic factor, and it is the most important prognostic factor for the breast cancer. Single most important prognostic factor is this lymph node metastasis. Overall stage, if stage is in the option, that is a better answer, but if they are single most important, it is lymph node metastasis. Mucoepidermoid type of breast cancer is answer. Although this is not a common cancer in breast, it is, you can say, just less than 0.5% of the breast cancers can be of this type. This is mainly you will see in salivary gland tumors, mucoepidermoid. And mucoepidermoid in the breast, it is a good type of cancer. Okay, it is better than other types of cancer. The lymph node metastasis is rare in these cases. Okay, lymph node mets is rare. Also, this is both ER, PR and HER2 negative. But we call it as triple negative, but this is better than the triple negative which we see in invasive type of ductal breast cancer or the other types of ductal cancer of the breast. Okay, so mucoepidermoid is the answer here. It is a better cancer than the other classical types of breast cancer. Next question, 35-year-old pregnant female with hyperthyroidism. Which hypothyroid drug is to be given? It is actually hyperthyroid drug to be given in the first trimester. Okay, see, Lugol's iodine is not given. Okay, methimazole, carbimazole, PTU, all these three drugs you can give in first trimester. All the three drugs, they will cross the placental barrier, but among this, PTU is the drug of choice. Okay, this chances of crossing the placental barrier is less in propylthiouracil as compared to the other. Okay, so generally in first trimester we give PTU, propylthiouracil, and when the patient goes to second trimester, we switch this to either methimazole or carbimazole. Okay, so from the second trimester, we switch it to methimazole or carbimazole, because see, PTU is given for the minimum period possible because it can lead to liver dysfunction. So that's why propylthiouracil people generally don't continue beyond the first trimester. Okay, in the first trimester, methimazole, carbimazole can lead to a rare congenital problem that is known as aplasia cutis, although that is not seen very frequently these days. Okay, so that is the reason propylthiouracil in the first trimester. From second, after the organogenesis is complete, you can switch it to carbimazole or methimazole. Next question, 50-year-old male patient, palpitation, headache, sweating, left-sided suprarenal mass. Okay, so these are the classical presentation: palpitation, headache, sweating, okay, flushing of the face, hypertension. All these are classical features of pheochromocytoma. And also they are showing that there is left-sided adrenal mass. So this is a left-sided pheochromocytoma. Which of the following would be done for the confirmation? Urinary VMA. Okay, this is the answer, urinary VMA, or you can go for metanephrin's level. Okay, if the patient belongs to high risk category, then you go for plasma VMA or metanephrin. High risk means if there is family history, if there are syndromes associated with it, then like Men's syndrome and neurofibromatosis. So there are 4 or 5 syndromes which are associated. So if the patient belongs to the syndromes or if there is family history, then you go for plasma. Otherwise, urinary is the answer. Okay, hydroxyindole acetic acid is done in case of carcinoid tumor. Myoglobin is done when there is myoglobinuria. Stool trypsin level has no role in case of pheochromocytoma. Okay, so the best answer is urinary VMA. Next question, chronic alcoholic female with chronic liver disease, sudden onset hematemesis. Okay, chronic alcoholic patient with liver disease, it goes in favor of portal hypertension. And in portal hypertension, when the pressure is more than 12 millimeter of mercury, there will be development of varices. Okay, esophageal varices or gastric varices, and that is the most likely reason for hematemesis here. Hematemesis is when the patient vomits out blood, that you will see in cases of upper GI bleed. So the most likely cause is here bleeding varices. Perforated ulcer, there is in the history, there is nothing like perforated ulcer, and also in perforated ulcer, mainly the bleeding is not the symptom. Perforated ulcer will present as peritonitis. Bohr-Haave syndrome, in that there will be a history of repeated vomiting that will lead to full thickness tear of the lower part of the esophagus. Mallory-Wade TS, again there will be history of acute bout of alcoholic intake leading to repeated forceful vomiting that can lead to a mucosal tear in the cardia part of the stomach. Okay, so based on the history, the best answer here is bleeding varices. Next question, a female patient after laparoscopic cholecystectomy with cystic duct stump leak. Okay, so when we do a laparoscopic cholecystectomy, suppose this is the cystic duct. So we apply clips on, 2 clips on the side of the CBD and 1 clip on the gallbladder side, and we remove it. Okay, these clips we apply on the cystic artery also. So generally nothing happens, but at times when this clip gets slipped, so in that case there can be bile leak from the cystic duct stump. So that is what they ask in the question. There is bile leak from the cystic duct stump. What should be the immediate management? Okay, immediate management in these cases are antibiotics and conservative management. Okay, conservative management, because cystic duct stump leak is not very dangerous. Most of the time it will resolve on its own. Okay, all you have to do is, if there is collection of bile in this area, just put a drain, let the bile come out. In case of cystic duct stump leak, another easy thing, if it is not closing spontaneously, you can do a ERCP and put a stent. Okay, a ERCP with stenting can be done. That is, after you start this, you have to give trial of this antibiotics and conservative management, and then if it is not stopping, if it is keep on coming on 3rd day, 4th day, 5th day, you can go for a ERCP and stenting. Roux-en-Y hepaticojejunostomy is generally required when there is when there is more than 50% of the main duct injury. Okay, like this, suppose this is the main duct injury. So when more than 50% of the main duct injury is there and that is near the hilum, then in those cases you have to go for Roux-en-Y hepaticojejunostomy. Okay, exploratory laparotomy you need to do only in those cases when the bile is totally spilled into the peritoneal cavity, causing severe biliary peritonitis. So in that case you need to open up the abdomen, do the abdominal lavage and put a drain and come out. Okay, so the answer here is the immediate management is antibiotic and conservative management. Next question, a 14-year-old boy is presented with absent left testis in the scrotum. on examination it was found in the superior inguinal pouch. What is the diagnosis? Okay, so when, see, suppose this is the inguinal canal, deep inguinal ring, this is superficial inguinal ring, and suppose this is scrotum. Okay, so what is undescended testis? Undescended testis is when the testis has never reached into the scrotum. Okay, it may be found on the superficial ring, inguinal canal, deep inguinal ring, or somewhere in the abdominal cavity. Okay, so that is undescended testis location. Ectopic testis is when it has crossed the superficial ring, but after crossing the superficial ring, instead of reaching into the scrotum, it has gone to some other sides. Okay, like this superficial inguinal pouch. This is also known as Dennis Brown pouch. Or it can go into the root of penis, or it can go into the femoral canal. So that is ectopic testis. In that case, it has crossed the superficial ring. Okay, so that is the answer. If it is in the superficial inguinal pouch, it is ectopic testis. Cryptorchidism is another name for undescended testis. Retractile testis is that condition where the testis has reached normally into the scrotum, but now it is going back into the inguinal canal because of the excessive cremasteric contraction. So that is retractile testis. In case of undescended and ectopic, the testis has never reached the scrotum. In case of undescended, it has never crossed the superficial ring. In case of ectopic, it has crossed the superficial ring, but after crossing, it has gone to some other site instead of going into the scrotum. Next question, 35-year-old male came to the OPD with swelling in the left scrotal region, and there is pain. Pain increases on standing, and in the evening it feels like bag of worms. This is a very classical, you can say, the image as well as in the question. It is very classical of varicocele. Okay, bag of worms appearance. There is dilatation of vein in the you can say into the around the testis and in the inguinal canal. So those veins, dilated veins, they can increase the temperature locally there, and that can affect the spermatogenesis. Okay, in testicular torsion, the history will be sudden, and that will generally you will see in younger patients less than 25 years. Suddenly there will be severe pain in the testis, and the testis rotates also. It goes higher up into the inguinal, into the scrotum. So that is testicular torsion. Epididymal cyst, you will see a very well-defined cyst which has transillumination test also positive. Okay, so that is epididymal cyst. Femoral hernia occurs not in this scrotum. It will be seen in the femoral canal on the medial aspect of the thigh. Okay, so varicocele is the answer here. Very classical. I am sure all of you have got this right. The patient presented with a history of bronchospasm. Tumor was present in the ileum with increased 5-hydroxy-indole acetic acid in urine. Again, a very classical bronchospasm, 5-HIAA. This is carcinoid. Okay, this is carcinoid tumor. So carcinoid tumor, this is a classical presentation. Carcinoid can occur in the GIT at multiple areas in appendix. It is the most common tumor. It can be seen in ileum, it can be seen in rectum, it can be seen in stomach also. Okay, esophagus, it is quite rare. So there are all the areas in the GIT carcinoid tumor can occur, and this is a classical presentation. Okay, bronchospasm, flushing, sweating, these are the classical presentation of carcinoid syndrome. Okay, it can lead to right-sided heart disease also. Right-sided heart disease, remember pulmonary stenosis, it can lead to tricuspid regurgitation. Okay, so right-sided heart disease, flushing, sweating, bronchospasm. So this is very typical of carcinoid syndrome. Neuroblastoma you will not see in the ileum. Chromatophenoma also not seen. Leiomyoma may be seen. This tumor arises from the muscle layer, but given the history and the increased 5-hydroxyindole acetic acid, it is straightforward carcinoid. Okay. Young female, 3 by 3 centimeter mass in the left breast, freely mobile. Young female, freely mobile mass in the breast. It is very classical of fibroadenoma. Okay, it is fibroadenoma. Phylloid tumor, generally you will see the mass is big. Okay, mostly more than 5 centimeter, a big tumor. Breast abscess, there will be some history of lactation, there will be pain, there will be erythema, tenderness, there can be pus discharge from the nipple. That is the presentation in breast abscess. Also they will give history of lactating female. Carcinoma breast, age of the patient is not in the favor, although age is not a very, you can say these days carcinoma breast can be seen in younger females also, but this tumor will be from the beginning, it will be fixed to breast tissue. Okay, it is not freely mobile, it is fixed to breast tissue. Okay, so in case suppose if this female comes to you for the diagnosis, confirmation of the diagnosis you can do by getting a ultrasound done. Young female, ultrasound is the investigation, and after that you can get a FNAC also to confirm it is fibroadenoma. Okay, next question. Postpartum female, pain and swelling in the left lower quadrant, fever, increased temperature, fluid collection. So this is classical of breast abscess. Okay, this is a very classical breast abscess. Okay, you can see swelling, fever, temperature, fluid collection, pain, very classical of breast abscess, postpartum female. Okay, so in this case, what is the treatment? See, conservative management you should not do in these cases. Antibiotics only, if you give only antibiotics, then maybe the pain and the symptom will resolve, but there will be a swelling that can later on mimics as malignancy, antibioma. Incision and drainage is now not the first line treatment. Okay, not the first line treatment these days. The first line treatment is ultrasound guided aspiration. Okay, ultrasound guided aspiration and antibiotics. That is the treatment of choice. You don't, like, you can ask, you can say like 7-8 years back, the first time when the patient comes, we straight away used to go for incision and drainage. But now that is not the classical treatment. You go for ultrasound guided aspiration and start broad spectrum antibiotics. Generally the organism is Staph aureus, so you give like amoxicillin to the patient, and when the report of pulse culture comes, you can change your antibiotic as per the culture sensitivity report. Okay, incision and drainage is done only in those cases when there is necrosis of the skin, and also when repeated aspiration and antibiotics the patient is not getting relief. According to the Bismuth classification, which of the following is type 3 bile duct stricture? See, Bismuth classification type 1 stricture is when, see, this area is hilum, or you can say hilar confluence. Okay, this part is known as hilum or hilar confluence. So if the stricture is more than 2 centimeters from the hilar confluence, then it is type 1. It is type 1. Okay, if this stricture is less than 2 centimeters from hilar confluence, it is type 2. Type 3 is when it is involving the hilar confluence, but the right and left hepatic duct and left hepatic duct confluence is maintained. In type 4, the right and left hepatic ducts are separated. Okay, right hepatic duct and the left hepatic duct are separated. The stricture has caused separation of these. And type 5 is when there is, see, this is right hepatic, left hepatic duct. Sometimes a aberrant right sectoral duct comes, and if there is stricture of that duct, it is type 5, aberrant right sectoral duct. So they asked what is type 3. Okay, they asked what is type 3. So type 3 is this option number C. Okay, this is 1. Option number A is 1. B is 2. C is this. D is 4. Fifth is this aberrant right sectoral duct. Okay, so that is Bismuth classification of bile duct stricture. Neuroendocrine tumor of pancreas associated with necrolytic erythema migricans is glucagonoma. Glucagonoma, which arises from the alpha cells. You will see necrolytic erythema migricans. Also you will see in these cases diabetes, dermatitis, depression, and DVT. Okay, so this is also known as 4D tumor. In insulinoma, patient will have hypoglycemic episodes. You can see Whipple's triad in these cases. In somatostatinoma, you can see diabetes, gallstone disease, achlorhydria, diarrhea. Vipoma, you will see very severe diarrhea. In these cases, that is known as WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. Okay, so this necrolytic edema migricans is a characteristic rash you will see in cases of glucagonoma. Next question, which of the following iodine isotope is used in the management of prostate cancer? It is iodine 125. Iodine 125 and palladium 103 are used as brachytherapy in carcinoma prostate. Okay, iodine 123 is used for the radioiodine scan. And iodine 131 is used for doing radioactive iodine ablation. Okay, so 131 is mainly a therapeutic. We do treatment from using iodine 131. Iodine 123 is for the diagnostic purpose. Both can be given orally. Iodine 125, you will see small seeds that you can put in the prostate for the brachytherapy. Iodine 125 or palladium 103. What is the name of this investigation? So you can see this is an oblique film where the dye is injected from here, and you will check whether what is the status of the urethra. Okay, so it is done to see the urethral stricture or the urethral injury. It is known as retrograde uretrogram. Okay, it is RGU, retrograde uretrogram, for the urethral injury or urethral stricture. Micturating cystourethrogram you will do in conditions like posterior urethral wall or vesico-ureteric reflux. In this, first you fill the bladder with the dye, then ask the patient to micturate, and you will see that the dye is going in the ureters in case of vesico-ureteric reflux, and the dye is kind of obstructing in the posterior urethra in case of posterior urethral wall. Intravenous pyelogram or IVU, better known as intravenous uretrogram, that is the investigation in which you give the dye through the intravenous route. The kidneys will take up that dye and they will secrete that dye in the urine. So wherever urine is going, your dye is going. So you can see in these cases the function of the kidney. You can see where is the obstruction, if there is any dilatation, all those things you can see in intravenous pyelogram. Okay, so answer, this investigation is retrograde uretrogram. Next question, patient presented with history of intermittent claudication. He used to walk for 400 meters, but now the claudication distance has decreased. Okay, so this is claudication distance. As the disease will progress, the claudication distance will decrease. He develops pain. Pain was exaggerated by lying down and improved by hanging the legs by the side of the bed. What is the most probable cause? See, this is pain on lying down, which improves by hanging the legs by the side of the bed, is very classical of rest pain. Okay, so this is a typical history that patient initially developed intermittent claudication. Now he is in rest pain. Next will be the stage of pre-gangrene, where there will be ischemic ulcer formation, edema, color changes, and after that it will form a frank gangrene. Okay, so this is how a chronic peripheral vascular disease progress. Okay, the most common reason is atherosclerosis. After that, Buerger's disease is also a very common reason. Female patient during washing clothes in the cold water exhibit color changes of her hand from the white to red. Which of the following drug is best suited for this patient? The patient is having Raynaud's phenomena. Raynaud's phenomena, in which you will see the color changes in the hand on exposure to the cold temperature. Okay, so initially when the arterioles goes into the spasm, the color of hand will be white or pale. After that, there will be accumulation of the deoxygenated blood. The color of hand will become blue, and on rewarming, the color will come back to red. So this white, blue, red is Raynaud's phenomena. If you don't find a cause for this, it is Raynaud's disease. And if you find the cause like atherosclerosis, Buerger's disease, trauma, vibrating tool workers, cryoglobulinemia, rheumatoid arthritis, SLE, these are the Raynaud syndrome. Okay, so the best drug or the drug of choice for this is calcium channel blocker. Calcium channel blockers are the drug of choice for Raynaud's phenomena. Also, we'll ask the patient to avoid exposure to very cold temperature, or they should wear the protective gloves or the socks for that. Chronic smoker, thin male, suddenly collapsed and brought to the emergency. Chest x-ray is given below. What is the step in the management? So if you see the chest x-ray on this side, it is totally, see, these are the normal bronchovascular markings. On this side it is jet black, and you can also see the trachea is deviated to the other side. So this is very classical x-ray of pneumothorax. And also you can say the male suddenly collapse. So collapse occurs when there is tension pneumothorax, which will cause the heart to rotate around SVC and IVC. That will lead to a type of shock which is known as obstructive shock. Okay, so in these cases, the next step in the management is large bore needle insertion into the pleural cavity. Okay, so generally we put this 14 gauge needle, which is approximately 18 centimeter, over the sheath needle. And this needle placement in case of adults, the site is 5th intercostal space in mid-axillary line. In case of children, it is 2nd intercostal space in mid-clavicular line. Okay, so the site of putting this needle is different in adults and children. And after the moment you will put the needle, a gush of air will come out, and after that you can put a ICD. Okay, so IV fluid, antibiotic, conservative has no role in this case. What does this X-ray depict? Okay, you can see this is the side where the costophrenic angle is normal. On this side, there is blunting of this costophrenic angle. So if there is blunting, it means there is presence of fluid here. Fluid. Okay, now this fluid can be blood if there is history of trauma. This fluid can be a simple, exudative fluid or transudative fluid, like you will see in pleural effusion. In pericardial effusion, on the X-rays you will not see much. You have to do for pericardial infusion either a ultrasound or a echocardiography. Pneumothorax, the image we have just seen, it will look jet black. Pneumonia, you will see the consolidation, not the costophrenic angle blunting. So this is pleural effusion. 50-year-old male, chronic smoker, OPD, cough, dyspnea, difficulty in swallowing, palpable lump was present in the neck. Smokers are most likely to develop which of the following? Okay, so a male chronic smoker, there are high chances of carcinoma of lung, and in the smokers it can occur. See, there are two types of lung cancer: small cell cancer and non-small cell lung cancer. In non-small cell lung cancer comes the adenocarcinoma, squamous cell cancer, and large cell cancer. Now, small cell cancer generally is, like, you can say 10 to 15%. Majority of the cancers are non-small cell. Small cell you will see only in smokers. Non-small cell you can see in smokers as well as in non-smokers also. And out of this, adenocarcinoma is the one which presents from the, or which arises from the periphery. In this case, they are saying that there is a lump present in the neck. So this apex of the lung comes in the supraclavicular area. So that is the area where there is tumor. So this is adenocarcinoma. This is adenocarcinoma which arises from the apex. Squamous cell carcinoma generally arises from the bronchus part, from the bronchus. Which of the following is used for the prostate cancer? Prostate cancer, there is Gleason score. In the Gleason score, the Gleason's grade is from 1 to 5 and the score is from 2 to 10. So that depends on the histopathology of the gland. Carcinoma of prostate exhibit heterogeneity in the histopathological examination. So two most common patterns which are seen in the histopathology are numbered from grade 1 to 5, and if you join both grade 1 to 5 on one set of pattern and grade 1 to 5 on another set of pattern, you will get a score from 2 to 10. Okay, the higher the grade, higher the score, poorer is the prognosis. Bethesda score you will see in case of solitary thyroid nodule. Alvarado score you will see in appendicitis. Nottingham score you will see in breast cancer. Okay, so answer here is Gleason score. After emergency tracheostomy outside the hospital, patient developed surgical emphysema. Surgical emphysema is a condition when there is air present under the skin. What is the most probable reason? The most probable reason is blockage, or this is tight suture. Tight suture around the, see, when you put the tube, you put either you will do suturing in that extra space, or you can put the dressing material around this. So when this dressing material or when the suture around the tube is too tight, the air can go into the subcutaneous space. Okay, air has to come out from here. Whatever little bit of air leak, if it is happening, it should come out from this opening. So if you make it too tight, then that small amount of air will keep on accumulating under the skin, and that will give this appearance of surgical emphysema. Okay, tight suture around the tube, or tight, you can say, dressing around the tube. What is not a component of splenic trauma based on? It is actually AAST. AAST is American Association of Surgeons for Trauma Grading. AST has given grading for all the major, organ injuries like spleen, liver, kidney, every organ they have given this grading. Okay, so parenchymal destruction, they see hematoma is mentioned there in the form of subcapsular hematoma or parenchymal hematoma. Vascular involvement depending on the hilar vessel injury, if there is more than 25% devascularization, that is grade 4. Parenchymal destruction depending on the parenchymal laceration, less than 1 centimeter, more than 1 centimeter, more than 3 centimeter, 1 to 3 centimeter. Adjacent organ involvement is not in the AAST grading of any injury, be it spleen or liver or kidney. Adjacent organ involvement is not a component of AAST grading. And this grading you will get on CT scan, and CT you will get in the patients who are hemodynamically stable. If the patient is unstable, go for fast and open up the patient. Which method is best for hair removal for surgery? Okay, hair removal, or you can say part preparation. This is done because during surgery, when you give incision in that area, you need to clear that area from the hair. So first thing is, you should not use a razor. Razor is now not used because if you use the razor, it can cause small cuts. In those small cuts, bacteria can go and stay, and it can lead to post-operative wound infection. So razor is not in the option. Hair removal before surgery by use of depilatory cream. Depilatory cream or the hair removal cream we can use, but that is again, it will create the field a bit messy and sticky. So that's why this is also not the preferred option. The best option is using the clipper. And this is to be done just before surgery, not a night before surgery. Just before surgery, you need to remove the hair by a clipper. Okay, either on the OT table or in the pre-op when the patients are waiting in the induction room. That is the area where you can remove the hair. So that is the best time to remove the hair. The best time to give antibiotics, prophylactic antibiotic, is at the time of induction, or you can say half an hour to 1 hour before incision. What advice will you give to the female patient before laparoscopic surgery? Eat full before surgery. If we ask the patient to eat full before surgery, it can lead to aspiration. Drink plenty of water. Again, it can lead to aspiration. Enema in the night before surgery is not required for a laparoscopic surgeries. Okay, this may be required in cases of loaded colon if you are going for a colorectal surgery, but not for routine laparoscopic surgery. This is actually NPO, nil per oral for specific hours. Generally, we ask the patient not to take anything by mouth for at least 6 to 8 hours prior to surgery. Okay, so that is the answer. Nil per oral for 6 to 8 hours prior to the surgery. Next question, which deficiency occurs after this surgery? See in the image, the surgery which they have shown is Roux-en-Y gastric bypass. Roux-en-Y gastric bypass, which is mainly a, you can say, restrictive surgery. This pouch of the stomach which we leave is around 15 to 20 ml, very small pouch. And then there is this alimentary limb through which the food will come. So we keep this alimentary limb between 80 to, you can say, 120 centimeter. So in this part only the food will come. In this part the bile and the pancreatic juice will come. So from here it will meet and the digestion will take place. Okay, so in these cases, when you do this bypass type of surgery, there is deficiency of iron, calcium, and vitamin B12. These three deficiencies can be seen, and in the option we have calcium. Calcium is the answer. Okay, if it is mainly a malnutritive surgery, then apart from these things, there will be also be deficiency of fat soluble vitamins like vitamin A, D, E, K. Okay, but this is not a mainly malabsorptive surgery. This is mainly a restrictive surgery. So that's why vitamin D deficiency or fat soluble vitamin deficiencies are not very common in this case. A family member is volunteering for blood donation with a person with road traffic accident. All of the following are tested. So generally we check hepatitis B, C, HIV 1, 2, we check syphilis and malaria. Okay, these are the routine checking in the donated blood. Hepatitis A nobody checks, okay, until unless somebody asks for it. Hepatitis A is not routinely tested in blood banks on the blood donated samples. Tumor cells secrete various hormones, chemicals which can affect various function. What it is called paraneoplastic syndrome. Like many times it will secrete PTH related peptides, so that can lead to hypercalcemia. Okay, hypercalcemia, anemia, polycythemia, hypoglycemia. There are lots of paraneoplastic syndromes. You can see generally you will see with RCC, you will see with hepatocellular carcinomas. Okay, so that is paraneoplastic syndrome. 23-year-old male, acute appendicitis, 3 days back, came to the surgery with abdominal tenderness. Which of the following incision is appropriate for this condition? Okay, the incision which is appropriate for this condition is this C. Okay, this is the McBurney's incision. Okay, you can go for either an oblique incision or you can go for a better skin crease incision, that is Lanz incision. Both are options mentioned in C. This 4 is Battle incision, which is generally, it is not given these days for appendix. 2 is midline vertical incision. Midline vertical incision you will perform if you are doing exploratory laparotomy. 1 is a subcostal Coker's incision. This you will give for gallstones disease if you are doing an open cholecystectomy. So the answer here is C. This is Phanon-Steel incision, usually done for gynecological surgeries. What is the diagnosis based on the given image? Okay, so this is a given image of a newborn where you can see dilated bowel loops. So there is some kind of intestinal obstruction. This is a cross table, you can say the inverted, previously it was known as invertogram, but now we do this cross table X-ray where we'll put a radio opaque marker at the site where there is anal opening should be there. At that anal dimpling we'll put a radio opaque marker, a barium sulfate paste we'll put, and then we ask the patient, we make the child lie on a 45-degree position, so the gas will come up to this part. So after this you will see that, okay, what is the distance between this, the proposed anal opening, and the gas shadow, and that will tell you that whether it is a low type of anorectal malformation or high type of anorectal malformation. Okay, so this is, you can say this is a anorectal malformation which comes under imperforate anus. Imperforate anus, anorectal malformation. It can be with or without the fistulas. The fistula can occur with the bladder. The fistula can occur with the vaginal wall. It can occur with the urethra. The patient presented with increased frequency of micturition. On cystoscopy, pale urethric orifice was seen. Bladder image is given. Okay, so bladder image is given on the X-ray, which is showing this, Okay, so see, certain things you need to understand. Carcinoma bladder, generally this is not the presentation increased frequency of micturition. Carcinoma bladder, they will have hematuria, painless gross hematuria. Okay, hematuria. Bladder TB, again in bladder TB you will see small bladder, okay, and a very small capacity bladder. Okay, that is known as thimble bladder, and you will see golf hole ureter, Schistosomiasis, you will see calcification of the wall. Malakoplakia is a very rare condition in which there is increased frequency of this micturition is seen. So given at the image of this patient, okay, this is the image which is showing on a you can say on a CT. This looks like a schistosomiasis. Okay, this looks like a calcified area there, so this is a schistosomiasis. Identify the type of fistula. The type of fistula they are showing is between the vagina and the bladder. Okay, so this is a vesico-vaginal fistula. Vesico-vaginal fistula is what they are showing in this image, between the bladder and the vagina. Okay, you can see in this image, this is the bladder, this is a uterus, vagina, this is a rectum. Okay, so there is this communication between bladder and vagina. Okay, chemotherapy was given for the bladder cancer. For which of the dose should be reduced if radiotherapy is given? See, cisplatin, gemcitabine and paclitaxel, they are radiosensitizer. Okay, so if you give these drugs, they will enhance the effect of radiotherapy. So these can easily be given. In fact, they are better if it is given along with radiotherapy. Ifosfamide or cyclophosphamide, they are a reason to cause bladder cancer, and generally we don't give these drugs in the bladder cancer. Cyclophosphamide, ifosfamide, they are the cause of transitional cell carcinoma of the bladder, and generally we don't need this drug, and if at all it is required, we give in a low dose. Okay, so ifosfamide is the answer. Graft in coronary artery bypass with long-term patency is internal memory artery, and generally we take LEMA, left internal memory artery graft. Okay, we can take this also, long cephalin, radial artery, PTFE, all can be used, but the best long-term patency you will see in internal memory artery, left internal memory artery. Burn patient brought to the emergency with involvement of whole back, posterior aspect of the neck and the gluteal region. So whole back means it is 18%, posterior aspect of the neck you can say 2%, gluteal region is 5%. So patient is having significant, you can say around 25% of the burn. So which of the following is the preferred treatment option? Resuscitation followed by isograft or allograft. Allograft you will take from the same species, that is not required. Healing by secondary intention, debridement and excision of burn skin followed by resuscitation, debridement of the burn skin. Okay, so the best answer is debridement and excision of the burn skin followed by resuscitation. Okay, the thing is, first you will do resuscitation in these cases. Okay, the first thing is resuscitation, and then you will put a graft there. Then you will put a graft. Okay, so the graft generally we use the autograft. So this is what I believe, that in the option, this is image based, so in the option there should be somewhere autograft is there when you take the graft from the same individual. So that is the answer, resuscitation followed by autograft. Okay, it should be autograft. Glasgow Coma score of RTA patient was 10. What is the severity? The range is from 3 to 15. If the injury is, if the GCS is 13 to 15, it is mild. 9 to 12, it is moderate. 8 or less than 8, it is severe. So this comes under this. So this is a moderate traumatic brain injury. Okay, moderate traumatic brain injury. 35-year-old male with gastric outlet obstruction, multiple episodes of vomiting. Which of the following fluid is preferred? It is Ringer's lactate. Multiple episode of vomiting, patient need a fluid replacement as well as electrolyte replacement. Ringer's lactate is the best fluid for that. 37-year-old female, alcohol intake, taking NSAIDs, severe pain. Radiograph is shown. This is showing a gas under diaphragm, which is seen because of perforation of the gastric or the abdominal hollow viscera. And if you see history of NSAIDs, alcohol, so it means there is some peptic ulcer disease which was perforated, and because of that the patient comes with the perforation peritonitis. Okay, so this is hollow viscous perforation. Hollow viscous perforation. Split skin graft for wound closure on the thigh includes epidermis and a part of the dermis. Epidermis and a part of the dermis, not the whole dermis. If you take the full dermis, it will become a full thickness graft. Full thickness. Okay, these are full thickness. Only epidermis is no graft. You cannot take only epidermis. Grade of glioblastoma multiforme. Glioblastoma multiforme is a very severe, or we can say very advanced type of brain tumor which comes as grade 4. It comes under grade 4. In an old patient after complete excision of glioblastoma, what should be done next? If the patient is old, the next management in these cases is give chemotherapy with temozolomide. Okay, chemotherapy with temozolomide is given for the patient of glioblastoma after the surgery. Which of the following drug is preferred for lowering of uric acid to prevent renal damage in tumor lysis syndrome? See, two drugs can be used to decrease the uric acid: rasburicase and allopurinol. Among this, allopurinol, it will act as a prophylaxis. But if the uric acid is already high, this is not going to reduce that. For that, the best answer is rasburicase. So if the question is, if they ask what is the prophylactic drug for a tumor lysis syndrome to decrease the uric acid, then answer is allopurinol. But if tumor lysis has already occurred and now they are asking to decrease the uric acid so that you can prevent renal damage, rasburicase is the answer. What is the next management for this type of injury where there is 3 days of road traffic accident, necrotic muscle, bone, visible genitalia, and Foley's catheterization? So primary closure is done when you do immediately. Okay, in these cases, 3 days of RTA, you should not go for a primary closure. Okay, amputation, there is no need. If the tissues are, if there is no frank gangrene, you don't have to go for amputation. Clean and close with rotation flap. Again, rotation flap in this stage when there is severe degloving injury, you should not do. What you should do is debride the dead and necrotic tissue and give hyperbaric oxygen. Let the healthy granulation cover it, and after that you will put a split skin graft. Okay, so that is the answer here. According to the image given below, the stomach of the woman, which specialist is needed along with surgeon? Okay, so I'm sure all of you identify this image. This is the image of trichobezoar. This is the image of trichobezoar. So in trichobezoar occurs in a condition which is known as trichotillomania. Trichotillomania or trichophagia, in which the females, they pluck their hair and they eat, and that keeps on accumulating, and that is trichobezoar. Okay, so trichobezoar, you need to do the surgery as well as you need a psychiatric evaluation for the trichotillomania or the trichophagia. Okay, so these were the questions asked in the FMGE June exam of surgery. All the questions were very straightforward, and I hope you did the exam well, and those who are preparing for the exam, you can see the questions are very straightforward. Okay, thank you very much. God bless you all. Best of luck for your exam.